Okay. Are we good with the IT and everything?
Are we recording?
We are recording.
This is, yeah.
I'm just looking to advance slides. Thank you, Michelle.
Okay, we will go ahead and get started. It is 1:01 on August 6th. This is our 2027 budget work session. So I will start with the roll call. Vice President Salt,
Here.
Commissioner Geithner should be here. She is not here yet. Commissioner Nelson,
Present.
Mayor Dixon,
I'm here.
Dr. Chan is not currently present or online, and then Dr. Collins has been excused for this meeting. Approval of the agenda. I need a motion and a second, please.
As Mayor Dixon will so approve, or so recommend. So move.
So moved.
One of those words. One of those words.
Commissioner Nelson has seconded. All those in favor of approval of the agenda, say aye.
Aye.
All opposed? Motion passes. Are there any board comments for our session today? We can just jump on in if there's anything. I'll just say I hope everyone's having a lovely summer and staying cool. It's good to see everyone. It's weird not seeing you all every month. Okay, moving on to item number 4, public comments regarding items not on the agenda. I don't think we have any. Anyone online? No one's in the room? Okay. Then the fastest pre-agenda items ever. Let's go ahead and move into our budget work session.
Thank you.
Deanne, turn it over to you.
Appreciate that. So I'd like to just start by acknowledging your time today as a volunteer board. We sincerely appreciate that you've scheduled this extra meeting and this extra amount of time together with us today to talk. I also want and I also forward in terms of the value of a work session and the opportunity to have this time together. So thank you for making that possible. And this work session today is intended to be a bit different than our August board meeting. At our August board meeting, we will bring forward our preliminary balanced budget. Today's session is really to give you context for that in advance of that meeting so that we have the opportunity to align around not just the numbers and the figures, but our planning, our strategies behind this, what we are prioritizing, and what we are planning to invest in. And one of the things that I'm excited about regarding our budget process this year as opposed to last year, a lot of our energy was on mitigating risks, mitigating issues that we needed to with changes in our financial structure, changes in what our organization could sustain. This year's conversation is much different, and we get to look forward to the future about how we can improve public health moving forward, what we can invest in for the future of the agency and our sustainability. And really, instead of focusing on the organization that we have today, and the budget to support our organization today, we want to move this conversation more towards what are we investing in for the future of our agency and how we are trying to stabilize and grow and mature within public health. And I'm going to pause here for a moment. Amanda, there's an echo, so I don't know, is that distracting anyone else?
On the backside.
Okay, I'm not sure.
I can hear it.
Yeah, I hear it. Not good. We're all crazy together.
It may be very distracting as I hear myself as I'm talking. But while Amanda is figuring that out, just also want to note some of the things that we are trying to change internally within public health. Historically, our budgeting process has been very much an annual event where we develop our budget at a specific cadence on an annual basis. As we've moved a budget team in-house that supports our operations ongoing in-house with our teams, we have kind of changed our approach so that we are focused on a continuous budget cycle instead of a once-a-year event. And I think that has served us very well because it also allows us to be thinking about and mitigating many of the items that come up throughout the year, operating on multiple different fiscal cycles. And that has also helped us move from budget being an annual event to budget really being a continuous process, and our preliminary balanced budget being the product of that process instead of a once-a-year event. And in the slide in front of you, you'll see kind of the philosophy that we're taking, which is we really want the opportunity to be looking forward about the organization we will need tomorrow, not just in the here and now. So that's some of the context around the purpose of today's meeting. And so I want to briefly go over our plan for what we're bringing forward to you today. We will spend a little bit of time talking about the context of public health and how we are funded as a local governmental public health agency. We'll talk about some of our efforts around financial stewardship, some future risks and our efforts to mitigate those, some strategic investments that we want to make into the future of public health. And we'll also talk about what we are anticipating in terms of our revenues and expenditures in '27, and then have time for some division-level budgets and board discussion. So although there's a lot of content in today's meeting, we may not need the full time, but as we go through this, we wanted to make sure we had enough time and that we didn't have to have a rushed conversation. And kind of thinking about where we are in our budgeting process, today's meeting is an important milestone in developing our budget, but this will be a continuous effort from now until our December 9th meeting, where we will bring forward our original budget for board approval for 2027. And we are slightly ahead of the general county cadence for budgeting. And there's a reason for that, and that is we have a statutory requirement to present our budget to the Board of County Commissioners on September 1st. So we've worked with the county administration to be on the agenda for that meeting so that we can meet that requirement. Yep. Yes, yes. And last year we were a little bit late in that cadence, so this year we will meet that requirement and appreciate the time to be able to do that. And then we will have the opportunity then to make any additional refinements at our October meeting and still meet our deadline for our adopted budget. So because we're at a slightly earlier cadence than the county as a whole, that necessitates some assumptions going into our budget. There are pieces of information that we have to make estimates around at this stage that may be refined as we go through that calendar process in developing our budget. One of the things that we're really pleased about is where we are right now in our preliminary budget, which is we are anticipating revenues at $26.4 million, and we are also anticipating that our expenditures match. So we are not anticipating a need for any significant structural adjustments at this time. Our revenues and expenditures align. Of course, there's some unknowns because we are this early in our budgeting cycle. So as we move through this time period, we'll get additional information that will refine our budget. That includes the county compensation plan. So we follow the county's leadership in the compensation plan. We don't know all of that at this point, so we're making some estimates there, as well as estimates regarding the county's contributions to public health. Those numbers may still be refined. And then another element that is not entirely solidified at this stage is we have several contracts that follow the federal fiscal cycle. So when we talk about our Women, Infants, and Children program, maternal child health, as well as our public health infrastructure funding, those federal funds we will learn more about closer to the third quarter of the calendar year. So we may have some refinements there as well. But one of the things that I think we as the public health leadership team are really happy about is those adjustments we made to our organization and our structure last year. We're seeing the results of that stability this year, and very pleased that as of right now, our staffing is aligned with our funding, and we are not anticipating significant need to change that moving forward. So that stability from those efforts, we're realizing those results in this year. Hi.
We're just wrapping up. We're
The good news, everything is good.
Doesn't usually take 25 minutes to get here from my office downtown. Sorry about that.
And then I just wanted to touch briefly on our fund balance. As we've discussed at various meetings, we do have a very healthy fund balance. We are anticipating that going into January of 27, our fund balance will be just over $7 million, about 28% of our revenues. And that's helpful to note at this stage because as we talked about some of the unknowns that will be further clarified, we do have room to consider some of those costs and utilization of fund reserve if needed going through this process.
Question, remind me, I think you probably stated it at a previous meeting, but do we have a target for the fund balance as far as percentage?
Yes. You want to speak to that?
18 to 21%.
18 to 21? Okay.
And I just wanted to take a moment as well to reflect on how we are working to strengthen our budgeting process and also looking at nationally recognized best standards. So you've heard us talk about, and even very recently, the Government Finance Officers Association and the awards that we have received for our budget book over the years. And I wanted to just speak to that briefly because the GFOA establishes some of the national best practices around governmental finance. Of course, we're very pleased to receive those awards for our budget book, but it's really more than the awards. It's about helping us think through our budget, apply principles from that, not just in the document and not just to receive those awards, but really to inform how we're thinking about our budget, mature some of our budget processes, and that's something that the team has all been involved in as well. And just one of the things that strikes me as we've worked through our budgeting process is the alignment with some of the principles within GFOA standards, talking about our priorities, our organizational challenges and opportunities, the value that we bring in our work to the community, and the value in how we are utilizing our financial resources, and then also being mindful of the long-term outlook of the agency, because that's been an important concern for us moving forward, is the financial stability of public health as a department. And then thinking a little bit about those best practices, they inform our priorities, they inform how we're thinking about this, and every budget reflects some of the choices that we make and are informed by not just where we are, but where we're going. So when we look at our funding and we're looking for opportunities to invest, we are trying to keep in mind that we want the organization to remain strong, regardless of what the next few years bring. And when reflecting on how public health is situated financially, one of the things I wanted to touch on is how local public health agencies are funded generally. Here you'll see a visual of our different funding sources that include state funding, local funding from El Paso County, as well as federal dollars, and our fee recovery and from license fees and permits. So we also can look at how our budget and how our funding aligns with other organizations. The National Association of City and County Health Officials every 3 years produces profiles of local public health agencies. One of the areas that is contained in those profiles is the funding composition of local public health. And we align with that in that most of our funding comes from governmental sources. A smaller portion is made up of fees, licenses, and permits, and less than 1% of our budget, less than 1% of LPHA budgets nationally comes from private or philanthropic organizations. So in terms of how we're funding, we very closely align with what we see in the national landscape of local public health agencies. And for public health in particular, our budget typically has about 50% of our funding coming from program-specific grants. So those program-specific grants, of course, are tied to very specific programs and services that we are contracted to deliver. So within our budget, it's not only up to us how we apply those funds, but we have to make sure the right funds are going to the right work so that we can stay in compliance to a commitment to more than 50% of our funding. And that's something that I know this team has been focused on, and it is a level of kind of increased effort from our internal budget team to make sure that we are very cognizant of and focused on grant compliance aspects as we move through. When we depend on 50% of our funding to come from those program-specific grants, that becomes very important to us, and that has been an area of focus for us this year as well. So those are our different funding sources. So then within our agency, where does that funding go? So like many governmental service-driven entities, the vast majority of that goes to personnel. When you look at where we spend our money, that's about 80% of our budget goes to personnel, 20% goes to operating, and then a very small portion goes to capital projects. I know in the past there's been some questions about how that aligns with similar entities. So we did look at other LPHAs across the Front Range in Colorado, looking at Adams, Arapahoe, Jeffco, Pueblo, and Denver, thank you, missing one. And those entities mirror us very closely with the majority of their budget going to personnel. On the lower end of that, a 60% allotment to personnel. On the higher end, 87%. So we're kind of right in the middle on how much of our budget goes to personnel costs. And then one of the things that we've been talking about and thinking about in terms of how we make our budget work and how we take into consideration all of our different funding streams to make the agency whole. Our funding is dynamic. So we have our county fiscal year, but we have inputs in the state fiscal year, in the federal fiscal year, and other changes that may occur throughout the year. Many of our funding sources come with constraints. That's inclusive of our program-specific funding sources. It's also inclusive of many of our fee categories where we don't necessarily set those fees. So we might not be able to have full cost recovery on some of those fees. One example that the board is familiar with is our retail food fees. Those are set by the state legislature. We're on year 2 of a 3-year phased-in plan to increase those fees, but it's not full cost recovery for us. We're also balancing all the multiple funding streams, and our funding streams come with different time periods, some one-time funds, some multi-year funds and renewable, some ongoing. And also something that we take into consideration is that many of our core statutory responsibilities, do not come with a dedicated funding stream. Examples of that include our requirements around our community health assessment, community health improvement plan, as well as our communicable disease program. They don't have dedicated funding streams, but we do have to prioritize funding to meet those statutory requirements that we need to deliver to the community. And within that context, then, our flexible funding sources become even more important to us. We have flexible funding through El Paso County. We have flexible funding through our LPHA funding from the state. And that becomes very important to us in some of those areas where we have statutory requirements that cannot be funded through grants or other administrative costs that we need to consider to make our organization whole. And then talking about kind of the fiscal landscape that public health is in, impacts to all of these different funding streams are that we have a lot of variability in our funding. We certainly experienced that last year as we went through some changes in longstanding funding sources and reevaluation of funding sources. Also, the costs of our workforce. And this is an area that I find exciting as a county employee. When I started about 10 years ago in El Paso County Public Health, we could not retain our nurses. It was a revolving door. We would get people in, we would train them, and then they would leave for higher paying positions. We had a very similar issue in environmental health where we were really training other agencies' workforce because we couldn't have the compensation to retain our staff. County as a whole has put a tremendous emphasis on compensation for our employees, and that remains a obviously considerable chunk of our budget, but we can see a tangible difference in the retention of our employees, our ability to recruit high quality employees when we have openings. So although those costs continue to go up, that makes a tangible difference for us, where we are able to retain staff, where we aren't the training ground for somebody else's employee. And that is something that in the last 10 years, I have really seen a difference in public health as a result of those efforts. So that's a wonderful place for us to be. Operations, that's also been an exciting area for us where we've really looked at a lot of our operational costs, trying to make sure that dollars that we put towards operations are not duplicative, they're not unnecessary, and we're really targeting those. We've also spent time as a leadership team over the last year and a half really trying to make sure that where we are utilizing flexible funding, that it aligns with priorities, that it aligns with the scope of services that we need to provide. And that's resulted in some decisions about efforts that we haven't carried forward as we make those priorities. And then as we go through this afternoon, we'll talk about some of the investments that we want to make in the future of public health that will help us navigate a dynamic landscape and be better situated for the future. And then, so thinking about that and thinking about the work that we've had over the last year, we as a leadership team have really been talking about and trying to move towards thinking more about stewardship of the organization as a whole, and that includes financial stewardship. And many of those efforts kind of come under 4 different categories. One is planning and making sure that we're making intentional decisions before our resources are committed, thinking about long-term and forecasting those needs, aligning our budget with organizational priorities. That's come out in some conversations about our statutory requirements, about chronic disease efforts. We've also been looking at building our systems and our operations to make sure that they are better serving the public, that they are efficient, effective, and making investments there. We've also been talking about accountability. And I think this is something that is very important to us, to be mindful that our public resources are being used responsibly. And that includes reviewing our programs and our positions, our organizational structure, and trying to make sure that that's aligned with our missions and priorities. And with sustainability, really trying to strengthen the organization for the future and not simply trying to mitigate today's problems, but really having an eye to the future. And we have some examples of that in action to share. So with planning, we have put considerable effort into improving our budgeting process, improving our budget monitoring process, providing training for all of our team members, and so moving those kind of identified needs into action. Lauren has provided training for our team on grant guidance, uniform guidance, to make sure we are elevating our attention to grant compliance issues. We've also strengthened accountability by reviewing our staffing, our programming, and our organizational structure. That relates to some of the decisions that we had to make last year to make our budget sustainable for the team. And it also relates to work that Kat has had ongoing within environmental health as it relates to accountability, where we are putting in place very needed structures so that our team can be more successful when we define expectations, we have set inventories, and we have processes to monitor that work ongoing. So that's been an exciting area of improvement for us moving forward. And then related to sustainability, we'll talk about some of the investments that we want to make in our budget for tools that set the agency up for further success. And so as we've kind of undertaken activities in all of these areas, what I think stands out to me as kind of the common thread through all of that, the common objective, is we are trying to position ourselves to be more adaptable and to better work in a complex environment where we're not just looking at the problem in front of us, but we're looking at how we work together, how our work is structured, and how we're monitoring that progress. So with that, we're also looking at future risks to guide some of this process. And as we talk about budgeting as a continuous process, that's a very important part of this, is to be considering those future risks. And we know that there's variability in our funding, and that's a risk that we need to consider. We know that the workforce is changing, technology is changing, expectations are evolving in the community. And although we may not control all of those factors, we don't control what may happen with the state budget and how that may impact us, what we are trying to do is position ourselves to be prepared so that we have options and we have flexibility as some of those factors impact us that are not under our control. The part that we can control and can be thinking about is how we prepare as an agency should those changes arise. So this has a couple of the things that we're doing to help mitigate risks. The first one is kind of about our staffing. And we know that structurally, as many of our grants come in, they tend to automatically go to personnel. New funding, new personnel, more personnel. But yet that creates challenges for us when we don't know the duration of some of our funding, we don't know the long-term sustainability. So something that we've been trying to balance over last year, moving into this year, is how do we have some baseline sustainability of our staffing, but still have some flexibility for areas of need. So we have been working with our partners in human resources to look at recruitment a little differently, look at job postings a little differently. So we haven't traditionally used a lot of term limited positions. So that's something that we're looking at as we consider some of our funding sources ending. looking at the potential for term-limited positions that can help us with defined projects in the near term without committing us to long-term staffing that we might not be able to sustain. Part-time positions, that's not something that we have traditionally had a lot of within public health, but that's also an area that gives us some flexibility in our staffing. And one opportunity that I'm excited about as we move forward is our team has been looking at the opportunity to do paid internships. Our human resources team has really moved the needle on our readiness to have paid internships and the availability to that in the community or in the county. We have strong partners at the School of Public Health, at UCCS, at Pikes Peak, where we could have the opportunity to have paid internships that not only help us with our work and help move projects forward, but then also helps us connect with the future public health workforce and give them meaningful exposure to the type of work we do, what it means to work in governmental public health. So I think that's an exciting opportunity. We have budgeted for some paid internships within our 2027 budget. And then we're also looking at utilizing more contracted support because not every project is going to equal necessarily a staff position. So how can we utilize, when we identify those projects, be more mindful of opportunities to leverage contract support to help meet the needs of public health while also balancing those long-term personnel commitments. So I think this is something that is exciting for us. It's a way to think about our work that's more flexible and adaptable and gives us options, but also balances some of those long-term commitments.
On that one, are you considering remote? So outside of our little bubble here?
So typically, no. Within the county, we do have in-person requirements for all of our positions. So we are not planning to look at our part-time, our interns, or our term limited as remote staff. But where that may come in is, of course, contracted support can look differently, and some of that project-based work may look a little bit different. But if we are going through our HR process, they would not be remote eligible. And I think that also speaks to kind of the type of work that we do. We've actually reduced some of our telework. So maybe a year and a half ago, we allowed 2 days in person, 3 days remote. The standard is now consistent with the county for 3 days in person. And all of our leadership team is 5 days a week in person. And given that a lot of our work is collaborative in nature, it's partnership-based, it's community-based, we have found that we really place a high deal of emphasis on that in-person opportunity. And then we'll talk some more about some of the systems that we want to invest in to help advance our work. And then we've talked a lot about a financial risk involved in Public Health South as a non-performing asset that we have more square footage than we can utilize. We have a lot of limitations we've discussed with that building. We did check in with the realtors on the status of that because that was one of the things we discussed was that we would have an update for this meeting. So at the last check-in with the realtors this week, their impression was that the change in strategy to a price listing was impactful. They have gotten more inquiries regarding the building. They have about 3 to 5 folks that are following up with inquiries regarding the property. So that's good news for us. And the rest of the facility, the strip mall, is also on the market simultaneously. So they are working with the broker for the rest of the facility to coordinate marketing strategies. Of course, none of that is an offer that we can bring forward for you to consider, but it is a little bit encouraging that that change in strategy has garnered more interest. At this point, they're not recommending that we consider a price reduction, and we'll continue to monitor that as we move forward. So some encouraging news regarding that facility. Then talking about some of the areas that we want to make investments in. Some of these we anticipate will start in this fiscal year, but carry over into next fiscal year. The first one up there, it's a little hard to read over there, but it is a grant management system. So we currently have about 50% of our budget coming from those program-specific grants, and we have about 25 different grants that we currently manage. For us, our grant management process has been dispersed across the agency, dependent on the program manager and coordination with our budget manager. And in that decentralized approach, that means there's a lot of individual variation. There's some challenges in making sure all of that information is collected in a similar manner, that we have the historical trends for some of those grants, and it makes it more labor intensive. So one of the things we've been doing in conjunction with the IT team, DST, as well as procurement, is to look for a grant management system. We have found a system that we want to invest in that will provide us with tracking mechanisms. It will provide us with the potential for some dashboarding that would help with the information we bring forward to the board when we talk about contract renewals, and to have some of that capability would be very helpful. It also will help us with alignment with uniform grant guidance and compliance issues. So not only does it help us to be more efficient in our work, but with those components of grant compliance, it also helps us mitigate some of the risk if we are not compliant with our grants. So that is a system that we really are looking forward to, because it will help us work more effectively at the agency level.
Does this plug into grants that you might apply for? Is this like a app store of grants?
Yes, so also as Carolyn helps us with developing grant applications, there are features of that that will allow us to look for grants, that will allow us to help in applying for those grants. So it will not just be the management component, it will also be development component and then the compliance.
Is there a grant for a grant management?
Is there a grant for a grant?
Surely there must be.
So it's one of the wonderful things about currently having the public health infrastructure grant from the federal government is it allows us to invest in systems that set us up for the future. So kind of, yes, there kind of is a grant for that, but we already have that grant.
Great.
And then one of the, oh, yes. Mm-hmm.
Really quickly, fun. Thinking about county overall has a lot of, so if you have, and how, like, are they already using?
Yeah, that was part of our process before we looked at an external resource. We wanted to make sure that there was not something within the county that we were missing. So we did touch base with finance, we touched base with DST, as well as procurement. And although many departments have different grant tracking, we did not identify anyone that had a grant system in place. And we also wanted to be mindful with the changes in the ERP that the county is considering, that we weren't investing in something that the ERP would essentially replace in 1 to 2 years. And it is our understanding that this would not be duplicative of that system either.
Guinea pigs and find something that can help the rest of the county.
Perhaps. And we are sharing where we are headed in those conversations with DST, with finance as well, so that any lessons learned, any opportunities, we're sharing that. Speaking of antiquated systems, our electronic health record. Summer could spend hours sharing the stories of how our electronic health system is antiquated and does not best meet the needs of the team. We've spent a lot of time looking at options related to that, And that is something that we want to pursue because it not only allows us better information for our clinical services, it is better from a data management perspective, a HIPAA perspective, as well as one of the things that stands out to me that's very difficult for our team right now is even sending in prescription orders. Our current system sends it in as a pill count, so we can't just send in orders for, a month's worth of something, a week's worth. We have to send in by pill counts. That actually increases our liability because it increases the possibility of errors. It's a very manual system. So it's really time to modernize that. So we have been exploring with procurement opportunities to modernize that. We've been looking at other cooperative agreements that procurement may be aware of for the most cost-effective way for us to modernize that system. But again, this is an area where that public health infrastructure grant allows us to invest in systems that don't just address something today, but set us up for longer-term opportunities.
What do we have today? And what are we looking at?
In terms of our EHR, our current EHR is Patagonia. And
Rest.
yeah, that's a cool name. That's a cool system. It's been high complaint. I started here, so and then as of right now, we are still in the various cooperatives that we have. We've chased down a few, looked at the cooperative, realized that they don't have, the appropriate terms and conditions, and, maybe some of them weren't competitively bid from whomever got that system in place. And so we can't just tack on to that. And so we are kind of casting the net wide. Looking at anything from Epic's Connect, right? So obviously not a full Epic system. We cannot afford that, too robust, doesn't make sense. But we do have Community Connect, various means, possibly being able to utilize something like Health in that route. Athena Health, MedTech, we're looking at all of them. But we're trying to see if there's a cooperative available, something to ease us into it. The RFP and that whole process is intense. We're involving our DS, our data team here, and then of course our operational staff to help inform us. But it's quite a bit of work, and so we don't really know yet. I wish I had a better answer. Long process.
I assume, are these like software as a service going subscription costs, or are these?
Yes, there will be upfront implementation costs and then ongoing costs. So we are also, in the context of an electronic health record, looking at the comparison for what we are currently paying with what a new system would cost. And so far, we feel like we can find something that doesn't outpace our current costs by a lot, but also makes a substantial improvement in our system.
And on the grant management, I assume everything's going to.
Yes, subscription based.
Yeah.
So the contract, the current grant helps us with the implementation, because usually there's a higher implementation fee, and then we will have to build this into our ongoing. But with the grant management system, they've been open to negotiation based on us being a public entity. So the system itself, we feel at about $19,000 a year is a good investment when you consider the financial and the grant obligations that system helps us manage better. Another area, and this is more truly a one-time cost for WIC. We are looking at working with an external contractor to help us assess our WIC services delivery model. We've talked about WIC at various meetings. It's a meaningful program that does good work. Our challenge is that the funding for WIC and the demand in the community, these things are not aligned. Funding is at best stagnant, at worst declining. At the same time, the demand for services is rising. So given that, we want to make sure that we have the structure, the processes in place, that we are delivering these services as efficiently as we can. So we are working with the external contractor to assess our service delivery model, to look at opportunities for us to structure differently, deliver services differently, and be more efficient within the resources that we have. So that's one of the things that we'll be utilizing the infrastructure grant to help us with, knowing that this is an ongoing balancing act with WIC as demand increases. So how do we make sure we're using the available resources as effectively as we can? And that work has initiated.
Are you using the new RFQ? I just gotta ask, have you guys seen this? Oh, their HHS has a new, it's like how to make like fast and whole food.
On a budget,
Like,
yeah.
on a budget, yeah, it's actually super interesting.
Yeah,
Yeah.
and it's a lot of that is, it's very similar to what we do in WIC. So there's a lot of overlap with some of those things with WIC service delivery, because that's one of the big teaching points they do with clients is around how do you take this WIC approved list of foods and make a healthy, affordable meal. We used to do some cooking classes on our own related to that. So having the opportunity to have some teaching resources that can help reinforce those messages, very much a complementary approach.
Can you, you know off the top of your head how much that contract is going to cost, and what the timeline is, and what we expect them to come back to us with in their experience?
Yeah.
I saw in that packet. I'm glad you brought it up because I had written it down as something to ask about the
Yeah,
Omni Institute.
And I'll ask Carolyn and Daisha to respond to that because they are working more directly with the contractor. So Carol.
Yeah, and so that contract is, we just finalized our scope of work, and so that's set to go through January, but it is fluid. But yeah, we're you know, an outcome of this assessment is really looking for them to help us map out any changes or recommended changes that they feel like we should make. We've been doing a lot of work on our own, but it's a great opportunity to have this third party come in. They do have experience with WIC. One of the people on the project has done other projects to support other WIC programs, so we feel good about that. But yeah, just making sure that we're, you know, working as efficiently and effectively as possible and utilizing the funds that we do get in the best way. Does that answer your question? Okay.
Things they'll be looking at is like clinic flow and how the work is allocated, correct, Daisha?
Yeah, that's correct. I mean, so looking for efficiencies, but also making sure that we're meeting our contract obligations. So, you know, taking a look at our co-location model, is that as effective as it could be? Are there other areas that we should be looking at? Are there other funding sources that maybe we're not thinking about that might come to light?
And will they also have insight? Because sometimes, I can't remember which other program it is, but there's sometimes some overlap. WIC, and it seems like one of our other programs sort of, I will have to come back to it. I can't remember what program it is, but
Here in public health?
yeah.
Are you thinking about SNAP?
Maybe I am thinking about SNAP.
It may be SNAP, which is the Supplemental Nutrition
It could
Program in
be.
DHS.
Yes. And so just like, do they have kind of that higher level perspective as well of like, the people who are utilizing WIC also are likely utilizing SNAP, and how do we make sure that both are being utilized to the best capacity, or, you know, that sort of thing. And if you don't know the answer, that's okay, but just maybe it's something to go back to them with of.
Yeah, absolutely. I definitely would want to think about that a little more before I just answer, but I think that's definitely something we consider. Like I said, we've developed a scope of work, but it's a guide in this, so
Yeah.
I think we can address that.
Good.
Other things that this will help us with, within environmental health, later this year, we will be working with the county's DST team on some process mapping for our environmental health team to look at potential for efficiency within environmental health, opportunity to improve some of our processes there. And although we're not anticipating a cost with the process mapping itself, we are budgeting for the potential for projects arising from that process mapping, so that if we have the opportunity to identify the public-facing dashboarding or information sharing that would help alleviate some of our communication barriers related to our permits, our turnaround, our processes, that could be an outcome of first going through the process mapping. So that is also something that we're excited to be looking at, because this has been one of the longstanding issues that we've been trying to improve around is turnaround times and communication to industry partners. So we'll be working towards opportunities to improve that for the partners that we work with. And also related to kind of a process improvement, Summer and her team will be looking at clinical billing capture within our clinical services division. We've talked in the past about we have a medical billing roundtable that their team started to work with other LPHAs to look at how we can recoup reimbursable costs for our clinical services. And with this project, the team will be looking for ways to improve that work that's already ongoing, as well as potentially looking at support for credentialing with Medicare. Currently, we bill Medicaid, but we are not credentialed with Medicare, so that could be an additional area of cost recovery for us. And then the final investment that we have listed here is also something that helps with one of our statutory requirements, which is to develop a community health assessment leading to a community health improvement plan. With this funding, we have explored contracting to support the data collection component, both for the community health assessment as well as public health accreditation. We are asked to have some primary data collection about issues impacting our community. So that is an area of interest. It's also an area of challenge for us within our capacity to do things like community surveys, to be able to capture that primary data. So working with a contractor to help support some of that component that feeds into our community health improvement plan, as well as feeding into our accreditation. And then this will be something that we'll be revisiting with the board as well, as we want to be able to be more connected as we work through our community health improvement planning process, and have opportunities at different points in time to bring that to the board, to get your input, including having the opportunity to speak to the type of data that we will be collecting through this process. But that gives us an opportunity to have a stronger community health assessment and to have that local data that is sometimes more challenging for us to gather. So that first part of this is really kind of about the background, about what we're thinking about, what we're prioritizing within our budget. So then that allows us to move into more of a high-level look at our revenues and expenditures that we're anticipating for 2027. We will not be going through every line item today, but to just give you a sense of what is changing in these categories, what is driving those changes, so that when we do come forward with a preliminary balanced budget, you have a sense of what is changing within our funding landscape. So first up is revenues. We have three main categories of revenues. The first revenue category is our fees, licenses, and permits. The significant changes in this category for us, we are projecting a decrease of $156,000 as our property sale program goes to required to optional. And then we are also continuing to project a reduction in our Medicaid reimbursements. We've talked about that previously. It's tied to a reduction in some of the client services that we provide, tied to people who have immigration relocations to El Paso County. So we continue to project that Medicaid reimbursement will be down. Increasing, though, we do anticipate that our laboratory fees in our public health lab will increase slightly based on volume and fee structure changes. And then we've talked previously about being in year 2 of 3 for the retail food fee changes set by the state legislature, and we anticipate that that will have an impact of $457,000 on next year's budget. Grants. As usual, there's movement in our grants. So starting with what has decreased or ended as a driving factor, the first one is one of our last pandemic era funding sources. This ended in April of 2026, and that was our epidemiology laboratory incapacity grant. Also ending is our Communities That Care. That was a 10-year funding cycle where we had substance use prevention programming specific to the Fountain Valley area. That 10-year cycle ended. And also we are at the end of a funding cycle for drug-free communities. Daisha will speak to both of these a little bit more as it relates to her division. And then we also see a decrease anticipated in our tuberculosis funding. The driver for that decrease in TB is that the statewide money allocated to TB has not changed, but the distribution based on case numbers is driving more towards Denver Metro. So as they reallocate that funding based on case numbers, we're seeing less of that impact in El Paso County, so more of the funding is going to areas with higher numbers of TB cases. New and increased, you're very familiar at this point with chronic disease funding. We had initially anticipated that that would be $200,000 per year, so a really welcome opportunity for us to have much more than we originally anticipated coming for chronic disease. We do have a new effort. This will be on your board agenda in August, as this is new funding for the board to approve, which is our overdose fatality review. Daisha will touch on that in her section. We've also seen an increase in our tobacco funding, tobacco prevention funding. And then we are projecting an increase in our A2 component of our public health infrastructure grant moving forward. Flexible revenues that support public health. We are early in this cycle, so we are making an approximation now for a increase based on previous year's projections from El Paso County. Of course, that will be determined later as we go through the county budgeting cycle, but for the purposes of planning, that is our planning assumption at this point. Also, kind of an interesting one for us is our state local public health funding. This actually increased for us in the state fiscal year, which was a bit surprising because this funding was cut as the state was mitigating some of their budget shortfalls. We happened to, based on population, receive an increase to our allocation. So that was some welcome news as we were anticipating cuts. to actually receive a modest increase. And then we've talked about our interest income, but it is a very small portion of our overall revenues. So then we'll talk a little bit about our expenditures as a whole. We are anticipating a reduction in our expenditures. And when we talk about our operations and the work we've been doing to make sure that we're using our operating funds wisely, this first one is kind of exciting for us. Each year, we've been spending about $150,000 to cover bank fees that are the convenience fees associated with utilizing a credit card. And other county departments have been ahead of us in implementing systems that allow the convenience of utilizing that card to be charged to the person who is making that purchase. This will allow us now, as we update that process, to do the same, and will have a positive impact on our overall budget. We will still accept other forms of payment, but this gives us a little more flexibility. And then we're also looking at trying to decide as we're considering the sale of a building, how do you budget for the next year for an asset that you are hoping you won't have? So what we did with that is we have built into our 2027 budget a 6-month assumption. So from today, that gives us roughly 10 months to hopefully have some type of resolution to that building. And that felt like a conservative, reasonable assumption that we could make in the budget. If that is not the case, we will be having ongoing conversations then with you about our strategy related to that building. But also, if carrying costs continue for that facility, one of the conversations that we would come back with is this an area where we could utilize fund reserve to help with those costs pending permanent resolution of that facility? We've talked about the decrease in some of the clients that we're seeing in immunizations. So along with that, we have decreases in vaccine purchases and supplies. So although some of those reimbursements are decreasing, some of the operating expenses related to that are also decreasing. And then we're also looking at some of the investments that we already talked about that will be around $200,000 for those projects that we previously discussed. Personnel. So in our 2027 budget, we will have a slight reduction in workforce. The majority of that is related to vacancies that we are not going to fill. As some of our operations change, so do some of our staffing needs. So we've identified some positions that we will not be refilling. And then we do have one position that we are going to sunset that effort. That's in Dacia's division, so she'll talk a little bit about that as she goes through her division. Within our expenditures for personnel, we also have cost allocation for some county employees who support our operations but don't directly count towards our FTE. So that includes allocation for human resources and financial services. And we are, of course, early in this process. So right now, our budgeting assumption is a 3% increase in compensation and a 7% increase in benefits. As we move through the year, we will continue to refine those estimates. So overall, our personnel costs have increased year over year by quite a bit as we consider those increases in compensation and benefits. Capital projects. I am happy to report our 2026 capital project, our vehicles. All of the vehicles have been received. They are at fleet. They are being outfitted.
I was just thinking about that.
Oh, were you? Okay. Yes, good news regarding that. So the vehicles are with fleet. They are being outfitted with the toolboxes so our team can have all the tools that they need in those vehicles, and then we're also currently working through the registration process. So we hope to have those out to the team soon. So, very exciting. And then, of course, our AV project, that has been complete as well. Capital projects, moving into 2027, we only have one small capital project at this time, and that is related to remodeling our environmental health customer service desk. As you go through our lobby, you'll notice we have a large open window for clinical services. We have a large open window for WIC. Environmental health is kind of set into an alcove. A lot of people miss the signage as they come in, and because the way that alcove is set up, it limits the number of customers we can serve at any given time. So we have been working with facilities to look at remodeling that area. For a remodel, $20K may look like a low estimate. That's because we anticipate some of that work will start this year, and that only a portion of that cost will be in the next fiscal year. We don't yet have full estimates for that project as we're working through that right now. So some of the key things going into this budget relate to continuing our work to establish that sustainable baseline staffing. We continue to look at our operations, our processes, look at areas for improvement. We'll have a modest but intentional reduction in FTE, and then also working to identify risks for the future and put in place strategies to address that. And something that I think has been really positive for how we work together as a team is we've also really been looking at breaking down some of the programmatic silos and working more flexibly across the agency within the resources we already have. And I think the chronic disease work is a great example of that, where we've not only had the opportunity to combine internal SME, but it also strengthens our agency. As our teams are working together, it helps us think differently about our work, collaborate more effectively together. So not only is it something that supports our budget, but it supports how we deliver and think about our work as well. So with this, that's kind of the background that we had, and then we were going to transition into some handouts where we'll walk through a little bit about division level budgets, but it looks like you have a question.
Okay, so on Pikes Peak Area Council of Governments, they are looking into getting engaged because of the senior transportation services potentially being hit by Medicaid cuts. Mm-hmm. It went from like $35 a ride down to like 12. And I don't know if that's potentially going to impact services that the health department provides or not, but we're looking at some pretty severe impacts, you know, pretty much across the board with under the senior services umbrella for the rides that were being paid for by Medicaid. I might have said Medicare. I might be wrong. It's Medicaid. So yeah, it's just an FYI.
Yeah, thank you. And this is something that is a benefit of having our medical billing roundtable. It helps us monitor what is happening in the Medicaid reimbursement realm. As of right now, we are not tracking significant impacts because we deliver such a kind of narrow scope of clinical services that are reimbursable through Medicaid. We're not anticipating significant impacts at this point, but of course, as the state goes through another budget cycle and looks at some of those things, it'll continue to be an area that we monitor. Any other questions before we move into some of the division level snapshots? Okay. So then in your packet, you should have a handout for each division. It starts with administration, So I will just talk through this briefly, because really in the background information we just went through, a lot of the priorities and processes in administration have already been addressed in what we've reviewed. But within our administrative division, this is related to our public health capabilities, as this is really where our leadership, governance, and all of the processes that support that reside within this division. Of note, we do pay about $3.25 million to El Paso County for services that support administrative duties and are captured within this division, including human resources, DST or IT legal services, and some of our financial management contracts and procurement. Interestingly, for public health, in the early 2000s, we were not integrated with the county in the manner we are now. So back in that time frame, we had our own HR, we had our own IT, we had our own facilities. And not having been part of those conversations at that time, I am really grateful for the decisions that that board made at that point in time to align with county services for these areas. We get much more quality services that allow us to align with the county, that increase our consistency and really help our agency be successful. So that's one of the investments made at the administrative division level that really does support our agency quite well. We've talked about some of the changes within Public Health South as a significant change that will impact the administrative division level. And then there are two of our grants. Typically, our programmatic grants will be reflected in the division level budgets. That is different for administration, where we have our chronic disease grant that has different agency impacts. That's held at the administrative level. The same is true for our public health infrastructure grant. That is held at the administrative level because it supports efforts across the agency. And one thing I would like to share regarding the public health infrastructure grant is that that grant, as we currently know it, is scheduled to end in 2027, and that is something that we are trying to be mindful of when we consider our staffing, when we consider the opportunities to invest in systems now. But with that, we do have a little bit of encouraging news as well, in that there has been conversation with federal partners about what they are calling a FIG 2.0, that they anticipate some type of public health infrastructure funding to follow the current funding. We don't know what that will look like. We don't know what that amount will be, anticipating we will get more information about that next year. But the potential for some encouraging news related to ongoing funding related to that. Any questions about the administrative level? A lot of this we covered earlier. Okay. So with that, we'll go to the next division.
All right, good afternoon. So I will speak briefly to our Strategy, Data, and Communication, or SDC division. This division is comprised of several programs. We have our Data and Analytics program, our Communications program, and our Planning and Assessment unit, which supports our Community Health Assessment, our Community Health Improvement Plan, among other areas. Something new you'll see this year in our 2027 budget is our Operations program and our Vital Records program also now report up through our SDC division. And this was the result of an organizational realignment, consistent with many of the themes that we have been focused on over the past year, taking the opportunity to assess vacancies. So when we had our business operations division manager became vacant, we took that opportunity and converted that position, which was a full-time, into a part-time project manager. So that has a few different benefits, namely that it's generating some cost savings for us, and it also is allowing for a little bit more of a project-based and targeted approach to the work. And so in kind of an alignment with that organizational change, from a budgetary standpoint, one of the biggest changes you'll see within our division this year is that we have revenue, and that is generated from the fees collected through our Vital Records program for birth and death records. That is something new for us, as typically the SDC division has been primarily infrastructure and support service programs, so generally we are agency funded and don't typically have revenue. So while this is not a new revenue stream for the agency, it is captured in a different way in our division budget this year. And then briefly, some of the themes that we are working on across the division, since we really do have infrastructure programs that serve not only all of our internal programs in public health, but also many of our external partners across the county and community and our residents. We have really been focused on breaking down silos in terms of everything from our tangible workflows, our processes, and how we collaborate with each other. And so working on a lot of standardization of our processes, more of how we approach the work with an eye for long-term sustainability. So that has looked a little bit like moving away from some processes that in the past were perhaps a bit overly reliant on person-dependent knowledge, and moving more towards some more cross-functional approach that supports stronger onboarding. So when we are recruiting and having new employees come into the division, they have a more clear kind of onboarding picture, and then succession planning in the long term, because we really have clear standard operating procedures across the board. So it's kind of a brief overview of our division and a snapshot of some of the work and just a few of the key budgetary changes that will be new and different for this year as opposed to last year. But happy to answer any questions. Thank you.
All right, great. So next up, Clinical Services Division. So under Clinical Services Division, just as a reminder, we've got our tuberculosis program, nurse family partnership, immunizations, and our preventative health services program, so formerly known as Reproductive Health Clinic. And I'll talk a little bit about why that name has changed. But within preventative health services, is reproductive health program, our work at the jail in syphilis prevention, and then now some of our chronic disease prevention efforts as well is housed there. As well within the division, our senior public health nurse, which I'll talk a little bit about in terms of how we utilize them, and then our billing and admin as well lives there. So some of the significant changes, we've talked a little bit about this already. So we're looking at, the addition, the evolution of chronic disease prevention work within clinical services, but not just within clinical services. We're also obviously working across the agency into different programs, and really trying to leverage our SME across the agency so that we have a really robust workforce that with the eye on sustainability of programming, regardless of what our funding landscape looks like. Again, I'll talk a little bit more about kind of some of that like organizational shift and structure here in just a minute. In terms of significant changes, we talked a little bit about our EHR, electronic health record modernization, the efforts therein. A big component of that, well, I would say like our big goal is to increase efficiency and effectiveness in the utilization of our EHR. It's really hard to do good work efficiently when you have people navigating systems that are not intuitive, that don't send correct information, that maybe squeak by from a compliance standpoint, but really leaves us open for liability with human error. Like pill counts was a great example of that. You have somebody on the back end having to calculate various numbers in order to get to the final number, which was the resolution that they gave us for this particular issue. And that just increases human error. So we're trying to avoid some of those things, really move into the modern era, if you will, in terms of an EHR. And then another piece of that are our referrals. You guys have heard heard me talk a lot about what we want to do with referrals, right? We don't want to just refer people to the community. I mean, we do, but we want to understand what impact that is having. And so if we can have a system that integrates more of a closed-loop referral process, which a lot of the better EHRs do, that allows us to give you all better data. It allows us to have better data and to inform decisions as we move forward, as we build these programs, and try and have better service delivery for our community. So that's the other piece. Yes, that is what we're planning. Yeah. We're really doing people a disservice by not having that patient portal. It is just such a basic thing. And so that is one of the pieces that we're looking at. And that also helps with, just from a HIPAA standpoint, being able to provide people with their records in a timely manner with no cost. Patient portals, if you have that available, it's there for them, and we don't even have to think about it. It's secure, and it's a way for them to access that. So that's another piece of this. And then in terms of changes, I wouldn't really call this a change because this is something that we've, done quite a bit in the last year and the year before, but continuing to evaluate our fee schedules, clinic workflows, and then position evaluation. So as the positions come up, if people leave, we're really not just looking, okay, let's refill this, but looking at it and saying, hey, what can we do, if anything different, to better utilize these positions? Could we, split a position? Could we broaden the job description so that we're able to shift and pivot, during emergencies and things like that? One of the positions that does that is the one I was going to refer to as our senior public health nurse, and they dabble in all the programs. They work a lot in our tuberculosis program because it's small but mighty. And so instead of hiring more and more people to help backfill and surge support, things that we can't predict, we have someone who now isn't overseeing individuals or budgets, but is helping programs move along their projects and then can shift into something like supporting backfill for tuberculosis. Like right now, we have a vacant position in the tuberculosis program, and so this individual is now able to step in, and oh, by the way, the manager of that program is now going to be gone for 3 months, and so having this position and being able to broaden that scope has really been super beneficial for us, and so we plan to continue to do that and to look at our positions that are available as we move forward. So efforts in our funding. So obviously, we have the Chronic Disease Prevention Grant as a new effort within clinical services as well as within community health promotion. But one of the things that we've done is integrate a singular position nested within preventative health services, formerly reproductive health, without needing additional oversight, additional personnel. We have this person nested in there. They are an RN. We can leverage their SME. They can focus specifically on chronic disease while working with other staff members. And oh, by the way, they can do Spanish translation, reach other community members that we need. I mean, really stretching our personnel in ways that are beneficial across the agency. This individual will also be working a lot with the individuals in CHP and working with other people who are going to help support the diabetes prevention program, for example. So that's a really exciting development. We might not house the actual grant itself in terms of funding. I would love to have that nugget right there in my revenue line, but that's not fair because it's an agency-wide effort, which yeah, right? We'll do a split. And let's see here. So another effort is really the exploration of additional insurance payer contracts. There are some real intentional efforts at evaluating the utility of Medicare. Is the juice worth the squeeze, so to speak, in terms of contracting and compliance that goes alongside that? And one of the ways that we are looking to evaluate those things is through some of the stuff that had been listed in terms of utilizing like one-time funds for contracted services to come in and say, hey, what are we doing in terms of billing? Are these best practices? Are we really getting that capture that we need to? And then also looking forward to Medicaid cuts. Some of our services eventually will be impacted because there are a pretty significant reduction in cost recovery from some of the services. And so learning how to navigate that and capture what we can with what we have. And so we're going to hopefully work with a company to help evaluate all of those things, all of our billing practices.
Do you have an idea at all on the missed billing opportunity with Medicare?
So yes and no. We don't provide a lot of services to individuals who have Medicare as it stands. We do have a bit in immunizations clinic where if somebody has Medicare, it would be beneficial for us. It's not a huge amount, and I don't have that number specifically. We had looked at it a few years ago and had this conversation preliminarily then. However, when we are looking at chronic disease prevention and the aging population, that is a huge portion of the population that needs our help. And so, for example, with the diabetes prevention program, Medicare, not Medicaid, Medicare has a fully reimbursable section, I don't even really know what you call it, within Medicare that allows for that. Medicaid does not. So that's an example of like really understanding, is the juice worth the squeeze? Can we utilize these? And do we set ourselves up for potential future revenue capture and cost recovery for some of that? And especially if some of our, chronic disease efforts end up developing into some of the aging populations. So optimizing our fee schedule, I talked a little bit about that. We're always doing that. It's an evaluation of like the fees that we set. Are they, industry standard? Are they, at the appropriate rate for individuals to be able to come seek our services? Because usually, people who need assistance are coming to seek our services. So always looking at the analysis and evaluation of that. And then I already talked about billing practices. So, and then some of the organizational shifts. We talked already a bit about it, but moving away from silos, working with our community health promotion division, but also data and analytics and other individuals across the agency to help support this work. Because again, we're trying to be super intentional that, yes, we have this grant funding opportunity and we're going to take it, and that's revenue that we need to get us off the ground. But should it go away at some point, we want to be able to sustain these efforts in a reasonable and responsible way and continuing to make positive impact with our community. And one other thing that we did, speaking of like good utilization of our positions and reevaluation, we have the opportunity to have an RN for the work that we're doing in the jail, an additional RN, which was originally in the budget anyway. And we decided to do like a 60-40 split with the reproductive health clinics so that they can support efforts there while also sustaining efforts within the Criminal Justice Center. And that's another way in which we're not looking to hire additional people, but really to broaden that job description and to help team members in a more sustainable fashion. So that's what I've got for clinical services. Any questions? Yep.
A couple of questions, and this might be a hard one. You can come back to us. I don't know if you know off the top of your head the numbers of how many different people your department is serving in a year. Like when we're talking about a health portal for individuals, I just would like to understand sort of the scope and reach that your department is reaching. And then my other question is, can you speak a little bit to how how does it work with, the jail has their own medical contract and services delivered versus, you mentioned doing a 60-40 split with one of our employees to support the jail. And so we're just sort of like, in addition, resource, and we're very minor in our presence in the jail and really they're depending on that other contract, or do we have a heavy presence there?
Yeah, that's a great question. And so when I'm referencing the jail, I'm talking about our syphilis prevention program. So we, as an agency here, do not like commingle with the medical services provided at the jail. This is a separate and apart from program. It is very narrow, and it is focused solely on reducing congenital syphilis within our community, within that group of individuals there.
So is it, if someone comes into the jail and then that contractor identifies that they have syphilis, then your department is notified to then do the follow-up with the partners and that sort of thing, or?
That would be great if that were happening.
Yeah.
And so, no, basically individuals come in, we have a list, they build out their testing list, if you will, of individuals that need to come down to receive services. And that's very nuanced, and I could get into that. But ultimately, when people come in on intake, they are medically screened from the medical company, that's not us, or the contracted medical group there. And they have obligations within a certain time frame to test for certain STIs and those kinds of things. Oftentimes, those individuals are in and out of the system before that mandate is required to be met, and they have other such high pressing issues, going through detox, wound care, diabetes, things like that are being addressed first, triaged. And so where we're filling the gap is we pull individuals, and especially there's like a risk-based process, and pregnant individuals, those kinds of things. We do the screening there on site. We receive results within minutes and can treat immediately, and then connect them to care once they get out for follow-up treatment. So our medical teams don't really cross paths too much.
Okay.
Yeah.
Thank you.
Yeah.
And just one other thing I was going to mention before we move on from clinical services. As a small clinical services team, many of us are double-hatted with different roles. One of Summer's roles is to be our HIPAA officer, as well as our clinical services director. And when we talk about HIPAA, that of course comes with financial considerations for liability and risk. And one of the things that I'm particularly proud of for our clinical services team is the fantastic job they have done in really improving how we talk about HIPAA, how we implement that into our processes, doing audits for HIPAA compliance in a way that we haven't in the past, but it's also opened up opportunities for us to work more closely around digital security with our partners in DST. So that is also something that Summer and her division have really spearheaded for our agency, is improving our digital security, working closely with DST, and helping make sure that we don't have liabilities in those areas. So there's also fantastic work occurring in that area.
Thanks.
Okay, I believe it's my turn. I'll be reviewing the chronic disease prevention, the community health promotion division, excuse me. So the community health promotion division is our WIC program, our maternal child health program, substance use prevention, injury and violence prevention, and currently our youth suicide prevention effort. And as I was looking at the year ahead, I thought about some of the themes that were rising to the top, and it's much like the agency, and you've heard from the other divisions, but I really feel like 2027 is going to be a year of evolution, alignment, and sustainability for our division. We are shifting from leading longstanding agency-driven initiatives to empowering more community ownership with those initiatives. We have new and exciting opportunities that to support innovation and cross-sector collaboration that I'm looking forward to, and we're making strategic operational shifts to support our long-term sustainability and our future success across the division. And so I wanted to start by talking about some of those long-standing agency initiatives. For more than a decade, our agency has led youth suicide prevention efforts in El Paso County. And over that decade, the community capacity has grown substantially. Our partners now have the infrastructure, there's trainers in place, they have leadership capacity to really take ownership and sustain that effort independently without our agency's leadership. So in 2027, we will be stepping back from that direct leadership, but we will continue to support by being a collaborative community partner. We'll provide data support as we can. But that is why, with us stepping back from that effort and giving that, handing that over to the community to sustain and lead, we will no longer need our youth suicide prevention planner position, and that's why we are sunsetting that position.
Before you move on, who are some of the partners in the community that we'll be relying on now?
So I know Changeline is a big partner in the community.
Or is it kind of like churches, or knowing that there's counseling available to citizens that are needing those kinds of services? Or
so there's several nonprofits in the community that we've been working with, and several different coalitions. I can't name them off the top of my head, and Dan, you may know.
One of the things I would say is there is a community collaborative effort around all ages suicide prevention. So a lot of our youth-focused efforts align with that. Partners at the table include school districts. They include Changeline. I believe Diversis has been part of that as well. So there's behavioral health providers, there's schools, Pikes Peak Suicide Collaborative, and at different points in times, there's been impacted families, there's been faith-based organizations as well. So some of the composition has changed over time, but comparing 10 years ago to now, we used to be the convener. We used to be the one doing the invitations, doing the coordination. It's really moved into a much more self-sustaining area, which is where that planning piece that public health filled as the community was just mobilizing for coordinated efforts has really changed considerably. They don't need that same type of staff level engagement because they're really self-sustaining in how they connect, collaborate, plan events, and take not just the youth suicide prevention perspective, but really more all ages and partners who want to engage in that.
Okay, thank you.
Yeah.
So additionally, another longstanding agency initiative or a grant that we have had is our Communities That Care grant that concluded on June 30th of this year. That marked the close of 10 years of service to our Fountain Valley communities. And over the past 10 years, they had formed a coalition. That work was really driven around a community coalition. And they worked to build a more connected and prevention-focused community to address youth substance use prevention. And although that coalition has ended, the leadership model will continue to support ongoing prevention efforts. An example is that, that community felt really strongly about continuing efforts around the Drug-Free Take-Back Day. And so I know partners at the library was very involved, law enforcement was very involved, the rec center was also very involved. Those partners have stepped up to continue those initiatives. And then I did just want to add that our CTC staff that were funded under that program have been able to transition into our substance use prevention program under our tobacco prevention funds. We did receive an increase in that grant as well as our innovative grant that allowed for that transition to happen. Another grant that we have that will be ending is our Drug-Free Communities grant. We've had that, and that ends on September 30th. We've had that grant for 5 years. It runs on a 5-year funding cycle. And we were eligible for that grant because it was tied to our Communities That Care program and that coalition that was operating there. So with the end of our Communities That Care grant and essentially the end of that coalition as we know it, we are not in a position right now to continue to have the Drug-Free Communities grant. But what we are doing is looking at our substance use prevention program and our current Tobacco-Free Alliance and working to expand our focus to more substances than just tobacco and vaping so that we can put ourselves in a position to be able to reapply for another funding cycle with the drug-free communities. So we're really looking at this as a pause and hoping that, through some of these changes that we're making that we'll be in a better position to apply. Another thing that we need to consider with that funding is that there are there are certain metrics that we have to be able to provide, and we have to provide those every 2 years, and that's, looking at, so among 6th through 12th grade, so youth data, which we've struggled to get, we have to be able to speak to past 30-day use, perception and risk of harm, perception of parental disapproval, and perception of peer disapproval. So we are also working to ensure that we can collect those metrics before we reapply, just to ensure our success. And then opportunities where we have to support innovation and cross-sector collaboration are through we are launching a new overdose fatality review pilot in collaboration with the coroner's office. I will be bringing this contract to you later this month. But as I mentioned, it's a pilot program. We're one of 9 counties in the state that are participating in this pilot. They reached out to us because of the work that we do with our child fatality review. The overarching goal of the overdose fatality review is to strengthen the community's understanding of our local overdose deaths, and then also identify opportunities to improve our prevention efforts. So again, I feel like this is a good opportunity, not only for our agency, but the community. It'll provide insights into and strategic direction, I think, for our substance use prevention program. We can take what we've learned and hopefully implement or strengthen some of our prevention strategies. It may also lead to a future collaboration with the Regional Opioid Abatement Council. So we're really excited about this opportunity to be one of 9 counties in the state for this pilot. As Summer mentioned, we Community Health Promotion is also implementing new chronic disease prevention strategies with funding from the Chronic Disease Prevention Grant. Much like Summer explained, hiring a position. We also hired a position, a lead policy and prevention specialist. This isn't a new FTE. This is one that we had, what's the word? Reallocated. Thank you. I just had to look. That we reallocated. And really, this position is going to support the effort as a whole, helping create alignment across our divisions, across programs, helping us make sure that we're fulfilling those foundational strategies. So not just the 5 strategies that we've chosen, but the developing resources and education, not only for our agency, but out in the community, making sure that our staff have the proper training that we need. What are the training needs out in the community? And so really just helping with that alignment piece, but that position will live within community health promotion. So really excited about that new position as well. Our division will lead prevention efforts. And I say lead, Summer and I, we've talked about it, and we need a lead for each strategy, but it's still very much a collaborative effort. Our division will lead efforts related to breastfeeding support and alcohol use awareness and substance use supports, but also be providing education and resource development across the other strategies, just as clinical services will be weighing in and providing support on the breastfeeding and alcohol strategies. And then I know I presented the new contract in June about our new innovative funding for the integrated tobacco cessation support and affordable multi-unit housing. That is also a pilot project. And it's an opportunity for us to implement a resident-centered cessation model that is delivered on-site through our partners with Homeward, Pikes Peak, and Greshio Housing. And then finally, some of the strategic organizational shifts that we have made to reduce silos, so another common theme that you've heard, and support our long-term sustainability is we have strategically and thoughtfully aligned all of our substance use prevention funding under one program, the Substance Use Prevention Program. Makes a lot of sense. But that we used to have our Communities that Care program, our Tobacco Education Prevention program, we had alcohol prevention under our Injury and Violence, and so we've consolidated all of that under the Substance Use Prevention program and feel like that's going to really set us up for success in the long run. It's going to help us coordinate our efforts and reduce those silos. And then again, it's an opportunity to take a look at a current coalition or alliance that we have, the Tobacco Free Alliance, and see if there are ways that we can expand on that to put us in a position for other funding opportunities. And then lastly, Deanne mentioned it, working with Omni Institute, WIC, assessing our WIC program. Again, looking at our organizational structure, operations, our staffing model, and just using our current realities and making sure that we're set up for success in the future, and being cognizant of the funding environment, and just making sure that we're thinking of everything and not having any surprises in the long run. So I'm thankful for that opportunity to be able to work with them and assess the WIC program. So with that.
I'm sorry. I feel like I'm talking a lot. I have maybe just a comment on that overdose fatality review, that contract or packet that was in our packet. It says that you'll be reviewing, I think it was something like 3 events, and that seems like a really low number when you're trying to get data trends. And so I just am putting that out there. Like, if you're really trying to capture data that is sound, only doing 3 reviews a year seems, in our size of a county, I don't know, it seems to me you would want it to be more like percentage based or something. So just food for thought there.
Yeah, and the overdose fatality review it's similar to child fatality review, but different. There are a lot of differences as well. And so really with overdose fatality, we will be working with the coroner's office and our partners to identify themes. Mm-hmm. Whereas child fatality, you're reviewing every child death. Mm-hmm. So an example of a theme could be, we've seen a cluster of overdose deaths at a park or in a multi-unit housing or among a certain age group. And so that is why the number is low, and it's a pilot, so given us some grace for the first year. But so to allow us to really dig in about the circumstances surrounding the theme that we decide as a team to review, and looking at prevention recommendations based on what we learned from that cluster of review, if that makes sense. So it's different that
Is it you're doing review of each case to identify the theme, or is it you already identified a theme and then you're going to go review all of the cases within that theme?
So we will have identified a theme.
Oh,
So,
I thought it was opposite.
yep, so we will have identified a theme,
Okay.
and so we may know that we want to look at these 5 cases because they died of a substance we've never even heard of.
Okay.
What is that?
Yeah.
Why? What
Yeah.
were the circumstances surrounding that? What were the touch points in those individuals' lives? And then really like looking at all of that context and gathering all of that data and then determining were there any gaps or any prevention, or were there things that were missed?
Okay, that's very opposite of what I thought.
And I would just add, I think one way to think about that is that the purpose of the fatality review is really more to get at qualitative information that augments and complements data trends. So, we can capture overdose deaths and the trends within that at the population level. But what we can't capture at the population level are the qualitative factors about clusters, about the substance that may enrich some of that overall population level data. So really looking at it to complement, but not replace population level.
That makes more sense. Thank you. I'm really glad I asked because I was really wondering. Thank you.
Thank you.
Environmental health. So we have spent an awful lot of time talking about on-site wastewater treatment systems this year. So you all know that that is part of what we do. There are many other things that we do in environmental health as well, including licensing and regulation of retail food establishments, on-site or public swimming pools, body art facilities, childcare, schools. Schools, childcare, and retail food facilities are all contractually obligated to us from CDPHE. So we work through a lot of those things. We are foundational public health service to the agency. Much of what we've been doing for the last year and a half has been working to level set the division in a way that we can build a strong foundation for environmental health. And that includes accountability, that includes determining, realigning with our core standards and our core program deliverables, and understanding what those are and the why behind why we do those services. We've spent a lot of time also building and looking to sustainable systems as well. And so creating sustainable workloads for our staff, ensuring that we have the right number of FTE to do the work that we need to do in a realistic manner, both in alignment with the FDA food code standards, which have a specific number of inspection requirements for each staff member, balanced with the other work that they do. And so many of our staff members are not solely conducting work within one environmental health program. So many of our consumer protection specialists is an all-encompassing term there. So they will do a schools inspection, they will do a food inspection, they might do a body art all in the same day. So we don't have staff who are operating solely in one program outside of OWTS, and our OWTS staff only do OWTS inspections given the volume of that work. But everybody else within our division really spreads throughout those programs. So we've done a lot of work to refine what their workloads look like and creating sustainable systems that we can build a solid foundation on for our staffing needs. With that, that also allows us to set predictable measurements for them as well. So we're not just looking at the number of inspections that they do, but the quality of those inspections and ensuring that they truly are risk-based inspections and not we're just going in to create a report that we don't need, that says we did the work. So a lot of that has been the last year and a half in creating sustainable, predictable systems, building a foundation that we can build off of long term. And so this coming year, we're going to keep building off of that. We're going to work towards ensuring consistent delivery standards for all of our programs. Now that we have our staffing numbers in a sustainable place, we understand what that looks like. We understand the core work that each of them are doing. We can now focus on our systems to improve turnaround times, our systems to improve our reviews, ensuring that we are maintaining our role within the program and not really expanding beyond our role. So areas where we can rely on engineering, we're going to rely on engineering. Areas where we need to ensure minimum service standards, we're going to ensure minimum service standards. So all of that is the basis for what we are doing in environmental health. Deanne has already talked about the couple of changes in our funding. We are anticipating a decrease in our property sale, what used to be the required property sale program to the now certified inspection program, as well as an increase in our retail food establishment licenses. That's based on the state. This is year 2 of that. If you recall, we were probably about 60% cost recovery. We're hoping to move closer to 75 to 80% at the end of this 3-year phased increase. So that is bringing us closer to being able to cover that within our programs. Another piece that we are working on with our budget team being in-house now is the environmental health budget used to be all one big budget, which made it really hard to understand the cost of each program. Are we covering those costs? What is our true cost recovery percentage? And working with Lauren this year, we've begun to separate out our budget by program. All of our smaller programs, we call them the SQUAB programs. So that's our schools, waste tire, water rec, childcare, body art, and air quality, with some other little ones mixed in there. They're all in one encompassing program. Our retail food will be one encompassing in OWTS. So we'll have a greater understanding moving forward of what each program costs us, as well as what are we recovering and how much are we spending within those programs themselves. Deanne also mentioned earlier that we are looking to increase transparency with our industry. We've partnered with the HBA and are working to build in some training courses with the HBA. We already have a partnership with Pikes Peak Area Realtors Association to provide education to them. So really trying to increase the transparency we have around programs, build in sustainable systems that we can provide training towards our industry members, and hopefully get more people in the room. We weren't able to get everybody in the room all the time, but if we can utilize our partners more, so increasing our partnerships, we can hopefully reach more people within our industry this year as well. So that's really all I have. Additionally, building public-facing databases where people can get access to information more quickly and efficiently, rather than having to call and try to get somebody on the phone. Changing our environmental health structure or office space structure so that we have more front-facing presence and we can help more people in that way.
And then I would just add, I think one of the other projects for the coming year as well is an assessment of locally controlled fees. Correct, Kat? Yeah.
Yes, so given the regulation revision this year with OWTS, encompassing as much as it did, we are going to look at our locally controlled fees in next year. So we'll start that process towards the end of this year with the intent of coming to the board to present fee revision requests. Probably October of next year is generally when we do that.
And for those fees, we do need board approval for those, so we will bring that forward. The last time those fees were updated was January of '24, so we are in a good time cycle to revisit those fees.
Looking at the numbers in the weeks prior to when it was required to when it isn't or hasn't been, we've seen about a 65% reduction.
In workload?
Yep, in workload.
Did you have like an hour, is that can you equate that in some way to what does that mean in terms of personnel usage and that type of thing?
I would have to get back to you on that to give you some sustainable, some real data on that.
Okay.
I don't have that off the top of
Just
my
trying to figure out the correlation. I mean, obviously you have a reduction in revenue, but you should have, it sounds like a reduction in workload as well that hopefully is correlating. So it'll be interesting to see when you do that fee study. And then my second really just comment is, lucky you have some of the most, I feel like, where a lot of attention has been placed not only on the OWTS side, but also on the childcare side. So I guess I would just ask if it's possible, it doesn't have to be anything formal, but there have been a lot of conversations happening in the community about the cost of childcare licensing and those things, and I realize that most of that is state-driven, but we are
in the mix of that. And so if there's any way that we can look at identifying things that in that process that are not truly serving the community well, and just keep a running, kind of list of those things along the way, that might be something that is really beneficial. I've been part of a small work group that Joint Initiatives has been working on with President of Council Lynette Crowe-Iverson, and there's still a lot of conversation happening right now around the regulatory burden and cost of those. And like I said, I know that is not, those aren't necessarily coming from us, but if we can help identify what those things are from perspective, when you have people, inspectors going out and going like, yeah, I don't know why they make us inspect for this. Do we really think this is really working? Is it really making, a tangible difference in the safety of the community, or are these things just regulatory burdens that we're hearing about consistently that are very difficult to comply with? I just think that would be a great resource for us. I know for me, and I would think, again, this is something that we could offer to our community that would be very valuable in helping to maybe be able to advocate with the state to reduce those costs that are truly making it difficult for families to be able to make ends meet, which ultimately leads to, I think it's all a big part of the spectrum on health. So just a request, if that's not overly burdensome, to just kind of keep that in mind.
Okay.
Yeah, I'll second that idea of just helping us understand and educate us on what are the state requirements and being forced by the state, and then where we do have some flexibility. Like, I've heard a story of a childcare center that had to add a second sink because there's a rule that you can't fill a water pitcher in the same sink that hands are washed. And like, where is that coming from?
Do you have to have 4 sinks, I believe now? We're up to 4 sinks.
I don't have the exact requirements for sinks off the top of my head for childcare, but I do know that all of our childcare regulations are from the state and they're contractually obligated to us. Licensing is separate from that, and we are just, like you said, a component of that. I know we have worked, there was one facility that they were going to be required to add another sink because they partitioned a room, and instead they went through a variance process and were able to add somebody else. And a lot of that does come from, if you're hand washing, especially if you're diaper changing and you're hand washing in there, then there's a risk of fecal oral route transmission. And because when you wash your hands,
it's a wonder we all survived growing up. Like, I mean, yeah, like, I hear you, but I'm also like, the reality on the day-to-day of us all living in homes that's happening all the time. And so I don't know. Like, I get if it's a state level thing, but yeah.
But it's like, yes, we could have discussion about the merits, but if there are things that you're seeing repeatedly that are problematic, I would just even say, not even making a qualitative judgment. Like, yes, if you definitely see ones that you're like, this is absolutely not necessary, that we could potentially advocate for. But even ones that are consistently a problem, I would say before we would even, the community as a whole, this board, anybody who wants to take action on that can deliberate the merits of it. I would agree. Lots of things about, what that means and whether we feel like it is, the juice is worth the squeeze, so to speak, on what those things cost. Because I'm going to go back to our all favorite example, COVID. It's like, you make decisions because it feels like you can divide everything up and it feels the safest. But when you look at things like the Great Barrington Declaration, where I'm finally grateful people are being held accountable for poor decision making. But when you make a decision like making health or child care unaffordable, they may go to a different center or stick them with someone else that's a less safe position. So you really have to look at the trade-offs. So anyway, I think we can debate those later. We can have those conversations at different locations, but just trying to identify the bottlenecks or identify the barriers to those getting open. We can always debate the merits later, but trying to track what those barriers are so that those conversations can happen and potentially be taken to the state would be, I think, a service that we have been asked for over and over again. I get asked all the time, it's local public health. I'm like, but is it a state requirement? And people don't really know, but we're really trying to help them separate that out so they can go advocate for themselves. It may not be something we even decide we want to, but just for them to understand those things. So that's why I'm asking. It's a huge topic in our community right now, and it's a huge need. So.
Yeah, so we can help be a communication tool for you or for those in our community that we're hearing from, and just making sure we're educated and understand. So that'd be great.
Okay. Good afternoon. Can you hear me? Okay, make sure I didn't turn it off. I'm Janelle McNair, the Acting Division Director for Disease Prevention and Response. As a reminder, the programs that are in my division are Emergency Preparedness and Response, Communicable Disease, and the Lab. The proposed 2027 Disease Prevention and Response budget does not anticipate any significant organizational or programmatic changes. Our division is going to continue its work and focus on preventing and controlling communicable diseases, also maintaining our emergency preparedness and response capabilities, and providing lab services that support disease detection and environmental health. But some of the changes that I do want to bring to your attention, and has already been mentioned earlier in the presentation, is that the ELC 2.3 grant has ended, and this is a reflection in our grant revenue for 2027. It's a 25% reduction from last year, but this was anticipated and planned for, so there is no impact to programmatic services. An additional change and something that we'll be looking at into 2027 is a laboratory fee review and assessment. This is to be working with our in-house budget team to assess the current fees and ensure that we're getting appropriate cost recovery for our services. The previous assessment was completed in fiscal year 2024, and that was the fee changes were implemented in 2025. So in sticking with the schedule that we've been adhering to within the agency of looking at it about every 3 years, we're up for that this 2027 year coming up. Our organizational shifts are really more looking beyond internally within the agency, so doing a lot of cross-jurisdictional training and exercises with our communicable disease program, our emergency preparedness and response program. A lot of emergencies and disease responses obviously don't stop at geographical borders. They, cross along the Front Range, so working with our partners in other jurisdictions as well, with sharing lessons learned, our after-action improvement plans, and working through those together is a shift that we've been making the last actually couple years since COVID. And then additionally, we're going to continue our strong collaboration and support with our Office of Emergency Management. We have, integration there through one of our emergency management specialists in our emergency preparedness and response program. Again, when it comes to communicable disease response, emergencies, partnerships, relationships, knowing who the person is on the other end prior to an event happening is part of being successful before the event even occurs. So we place a lot of emphasis on partnerships, relationship building, attending external trainings, external exercises, and being integrated in the community as much as possible. And then some of the other things that we're looking forward to for the next year in 2027 is our Project Public Health Ready. I have mentioned this in previous presentations, and I'm sure I'll have an opportunity to present this again to you all. But this is where our agency gets to submit an application for national recognition on emergency preparedness and response. It's a very, very heavily involved, detailed process where we submit plans, exercises, after-action improvements, trainings from the past 5 years, and then we're assessed against national standards. We're currently the only agency in Colorado to maintain that recognition for emergency preparedness and response. So as a division and as an agency, we're excited to pursue that in 2027 as well. Additionally, we have some exercises planned for the agency and also working with our external partners. Communicable disease is going to continue to evaluate the implementation of their disease dashboards that launched in May of 2026 to make sure that those are working as intended, or if there are any identified needs to make improvements. And then with our lab services, continuing to assess the lab fee and cost recovery assessment, and then also exploring integration into regional biothreat detection and response support throughout El Paso County and even beyond our geographic boundaries. So, any questions?
In your packet, you talk about your doing conference presentations, professional publications, worker participation, and innovation award submissions. What's the topic?
Yeah, so it's actually a range of topics. So, for example, in communicable disease, they submitted 2 publications and a manuscript related to the 2025 measles response. One of those was to the New England Journal of Medicine. The other one is to the Pediatric Infectious Disease Journal. We also presented at the Colorado Emergency Management Association in partnership with the Pikes Peak Regional Office of Emergency Management on mass violence recovery, which is a plan that the county has been working on with several different partners, and public health has been a strong partner in that, so had an opportunity to present. And then also at the CSTE conference, we had 3 presenters from communicable disease present on some of their work that they've been doing there as well. So we continue to pursue these opportunities to take, again, what I've emphasized is these lessons learned and not just keeping them internal within our agency, but sharing them with our cross-jurisdictional partners, Colorado partners, but even beyond that on a national level. So that's something that we are continuing to place a lot of emphasis on as well. Yeah.
So that is the information that we compiled for today's conversation. If you have additional questions or any concerns that you'd like us to consider prior to the preliminary balanced budget presentation, we would love that feedback and anything that you would like us to further consider.
This was fantastic. Let's do this every time.
This packet was awesome.
Yeah.
Oh, thank you.
So good.
Thank you.
Post this online for the public, or a version of this and what we started with.
Yeah, thank you. I mean, we are looking for ways to provide better information that is concise and easy to follow, so thank you. We'll consider that.
Also like this one, grant revenue changes, having that all in one place is really helpful.
I'll say in addition to just the materials being fantastic, is it's very clear and obvious, putting a lot of thought and effort how to make it and the best something that is not and takes a tremendous outcome out, but definitely showing in the end result. And I know it's going to only continue to get better with the plan that we'll have.
Well, I thank you for that, and definitely thank the entire collaborative effort from our team, budget, and the board. It does feel lovely to be having a different type of conversation this year than some of the more imminent decisions that we needed last year. So it feels like a good place to be.
Anything else? Okay. Meeting adjourned at 3:12. We'll see you in about 3 weeks.
In a couple weeks.
Couple
Yep.
weeks.
Yep.
Okay.
August
Thanks,
26th.
everybody.